Hello everyone, my name is Denise Bernal. Today I'm going to be presenting my case study who is about Pablo Mendez, a Mexican male with end-stage renal disease and Uremic syndrome. Pablo Mendez is a 78 years old Mexican male with a long history of type 2 diabetes. He also has hypertension. He's been on dialysis for 8 years. His history has diabetic neuropathy, mild retinopathy, and past diagnosis of colorectal cancer, which has been on remission for the last 8 years. He smoked 2 cigarettes per day. He lives alone, and his mobility is mild. He still can do independently activities. He denies alcohol or drug use. Mr. Mendez presented to the emergency department the other day with shortness of breath that was worse during activity, severe fatigue, swelling in both legs, and loss of appetite that was causing weight loss. His friends that bring him to the ED reports increased confusion after dialysis, which was very unusual for him. These symptoms aligns with fluid overload, anemia, and uremic toxin buildup, common in patients with kidney failure. Mr. Pablo reports shortness of breath during activity, severe fatigue, nausea, poor appetite, muscle cramps, insomnia, foggy mind, tingling and burning on his feet that are worse during the night. His vital signs show that he had elevated blood pressure, respiratory rate is between 20 and 22 but is visibly agitated. He has pale conjunctiva, dry mucous membranes. He has edema on both legs, pitting 2 crackles during auscultation. Patient labs shows that hemoglobin is low on 8.3 and the serum potassium is elevated, same as BUN and creatinine, and the KT/V suggests inadequate dialysis clearance. So those findings support that his symptoms are related to end-stage renal disease complications and possible uremia. I choose 3 differential diagnoses. The first one was congestive heart failure, the second one is anemia, and the third one is Uremic syndrome. The first, heart failure, occurs when the heart becomes too weak to pump the blood effectively, and then if the blood doesn't move forward naturally, fluid is going to start building up in the body, and this is going to cause shortness of breath, crackles on the lungs, swelling, and fatigue. This patient is at higher risk of cardiovascular disease because of diabetes. The second diagnosis is anemia. In chronic kidney patients, the kidney produces less erythropoietin, and inflammation further suppresses red blood cell production. Because of this, can result in anemia. In Pablo's case, this patient has the hemoglobin low at 8.3, and he also presents pallor and constant fatigue. Those findings strongly support anemia related to chronic kidney disease. The last diagnosis that I choose is Uremic syndrome. Uremic syndrome is going to occur when the kidney fail and the body can no longer eliminate metabolic waste. This condition is going to affect multiple systems in the body, including the brain, the GI tract, the skin, the cardiovascular system. Common symptoms for Uremic syndrome is going to include nausea, loss of appetite, nerve pain, itching, change on the skin, and the laboratories are not going to be normal. For example, the BUN and creatinine are going to be higher. You're going to have hyperkalemia and hyperphosphatemia. I choose Uremic syndrome as my final diagnosis, and this is because Pablo's kidneys are no longer able to remove toxins, regulate electrolytes, and maintain fluid balance in the body. That's why he had electrolyte imbalance, especially hyperkalemia and hyperphosphatemia, which are important hallmarks for uremia. Also, Pablo is experiencing symptoms from uremic syndrome, such as fatigue, nausea, loss of appetite, itching, and episode of confusion. This is happening because the waste and that the kidneys are supposed to remove are not being removed and now are circulating in the bloodstream and are affecting multiple organs. Genetic predispositions plays a role in the Hispanic and Latino community. They have higher susceptibility and faster progression of kidney disease, and this is because of the genetic background and socioeconomic factors. Also, the inflammatory process and immune activations are major contributors. This is because excessive inflammation in the body damage the nephrons and cause the release of cytokines. This chronic inflammatory state that the body is suffering is going to weaken the bone marrow function, which makes anemia worse in patients with end-stage renal disease. Finally, the immune response system suffers change. Neutrophil dysfunction increases the patient's susceptibility to infections, and abnormal T cell functions contributes to persistent inflammation and reduce the ability to fight for infections. All those factors together, the genetic, the inflammatory, and immune factors, play a role in Pavlov's disease progression. In uremia, the immune system becomes suppressed, and this is because the uremic toxins impair neutrophils and T cell functions that is going to increase their risk for infection. Other organ dysfunctions are going to include fluid retention, hyperkalemia, acid-base imbalance, phosphate retention in the body. All these conditions are going to contribute to develop pulmonary edema, arrhythmias, bone mineral disorder, and is going to make the fatigue worse. The heart, to compensate the fluid overload and the high blood pressure, the heart change and then is going to develop ventricular hypertrophy, worsening hypertension and increases the risk of heart failure, which is going to be very negative for the patient's outcomes. Different biochemical pathways are involved here, including the renin-angiotensin-aldosterone system, which increase the blood pressure and stress the kidneys. Also the calcium phosphate imbalance that is causing bone complication and oxidative stress from the hyperglycemia. All those things contribute to vascular and kidney damage. This mechanism together explain the full picture for Pavlov's uremic symptoms. To assess Pavlov's complications, different tests are performed. For example, comprehensive metabolic panel, which is used to measure the BUN, creatinine, potassium, phosphate, and bicarbonate levels. This is going to reveal signs of kidney failure and metabolic acidosis. The other one is going to be a complete blood count or CBC. This is going to evaluate anemia, which often presents as an hemolytic due to low erythropoietin production and inflammation in patients with kidney failure. The EKG also is going to be used to test and detect heart electrical change from arrhythmias and increased peak T waves, which is going to indicate hyperkalemia, and this requires immediately attention. The chest x-ray that is going to help us identify pulmonary congestions and help make a difference between kidney-related fluid accumulation from heart or related edema. The blood glucose and also the A1C test is going to monitor the blood sugar from the last 3 months to see how is the behavior from sugar blood in the system to create a plan and help the patient to have glucose controlled. Also the dialysis adequacy test, which is going to measure the effectiveness of dialysis in removing waste from the blood. Management is going to include both acute and chronic treatments. For acute treatment, we're going to focus on adjust dialysis based on the KT/V to remove toxins effectively. For chronic treatment, includes long-term dialysis optimization, Regarding medication, we're going to use ESAs like erythropoietin medication for anemia, phosphate binders for hyperphosphatemia, RAS blockers for cardiovascular protection, and insulin or GLP-1 agonist to control diabetes. Also, we're going to do lifestyle modifications, which is going to be the patient is going to be educated to have low potassium diet and control protein intake, of course, fluid restrictions and diabetes nutrition counseling. This is very important for the patients. Also, we're going to provide supportive care, including physical therapy for muscles that are damaged, for weakness, neuropathy treatment. We can include gabapentin or duloxetine. We're going to offer social support and transportation to dialysis to make the patients be adherents to the treatment. Mental health support is going to be offered. Also, it's necessary to be checking monthly labs, blood pressures, and very important to do routine food exams and annual oncology screenings, especially for Pablo that had a past history of colon cancer. Several complications can develop, such as uremic encephalopathy, that is going to occur when toxins build up in the body and reach the brain, leading to confusion, cognitive decline, and in severe cases, seizures or coma. The other one is cardiac arrhythmias due to hyperkalemia, which disrupt the normal heart conduction. Other one could be fluid overload. Fluid overload is going to happen because the kidneys can no longer properly eliminate sodium and water, and this is going to result in swelling and increased strain on the heart. Continue with the complication. Another one is malnutrition inflammation complex syndrome. This is going to occur because uremia causes inflammation and metabolic acidosis, which is going to decrease appetite in the patient. It's going to make the immune system weak in his function, and patient is going to stop eating. Bone mineral disorder is another one. This is going to develop due to elevated phosphate levels, triggering secondary hyperparathyroidism, which is going to lead to bone pain and higher risk of fractures and vascular calcification. This is especially in old patients. The last one is going to be infection risk, which is increased because the weakened immune system, and also combined with multiple access points from dialysis. Patients have CVC lines and graft or arteriofistulas that can develop infection and create sepsis or make patients more susceptible to catch any infection. The prognosis for the patient Pablo Mendez is going to depend on the following dialysis treatment schedules and how effectively he managed the conditions like diabetes, hypertension, and other comorbidities that he had. Proper management can reduce hospitalizations and improve his quality of life. For long-term outcomes, the only option it will be a kidney transplant. This is the best solution because it's going to restore the kidney function and significantly extending his life expectancy. But unfortunately, he is not a candidate. So the only option that he had is to be adherence to his dialysis treatments and his diet and manage his comorbidities. Thank you for listening to me. I hope you enjoyed this presentation as much as I did. Thank you.